I invite Dr. Ashish Sharma to speak his talk, to give his talk on the BIRA study. Ashish Sharma, as we know, is associated with the Lotus Eye Hospital, but he is known for his prolific publications that he has and the studies he has got. He has done his retina fellowship from the Irvine Institute in California, and then he has done his additional retina fellowship from the Bascom Palmer Institute. We know Ashish for the numerous presentations that he's done and his innovations for the RetCam that he has done. He's got the patent pending for the fundus imaging device called the N2 RetCam. And of course, he's been given the International Ophthalmologist Education Award by the American Academy. He's on the editorial board of most of the high impact journals. So I would like to call Dr. Ashish Sharma to give his talk on the BIRA study. Ashish.
Thank you, Dr. Nishikant, for kind introduction, and regards to Dr. Pramod. And all the colleagues, good evening. So can you see my slides?
Not yet, Ashish.
Now?
Yeah, now it's seen. Now it's seen. Yeah, definitely.
Okay, so good evening, everyone. And I'm going to present our recent paper, which we published, and it came online just 2 to 3 days before. And, it was ranibizumab biosimilar versus Lucentis in cases of neovascular AMD, efficacy and the safety analysis. The name of the study is called BIRA study. And I would like to acknowledge the contributors and the help from our international colleagues. And especially I would like to highlight the contribution and the help from my two of the very bright DNV candidates, Dr. Nilesh Kumar and Dr. Nicola Parachuri. We have been publishing in the area of biosimilars since last couple of years, and these two students have been very, very instrumental in all the work. So regarding financial disclosures, I do have financial to disclose because I'm consultant for INTAS, and this is basically an INTAS platform for this particular session. So this is the study that we published, came online 2 days before. The question was that why was the need of this kind of a study? Because we had a lot of data in terms of Razumab about the safety and efficacy. We have no doubt that the drug is safe and efficacious because you see the data from Disha with phenomenal data from 9,000 plus injections. And personally, we all clinicians have sensed and we have felt it that the drug is no inferior to the originator drug. So why was the need? But if you look at the data which is in the published domain, there was no data which was comparing Lucentis versus the biosimilar Razumab. So although we all clinicians know that drug works as good as Lucentis, but there was nothing on the published domain. So there were a lot of multiple single-arm scientific studies were published. So we felt the need. And then the study design was retrospective chart review of treatment-naive neovascular AMD patients. We had at least mandatory 2 visits to be included in the study at 4 weeks interval, and whether they were given Razumab or Lucentis. So between 2018 to 2020. And minimum of 8 weeks follow-up, obviously, because we have a couple of injections mandatory here. And we have excluded all the patients who had anything other than neovascular AMD or any kind of vitreoretinal interface disease. And we watched these patients for next 6 months, but our primary outcome was at 8 weeks, which is in line with the international recommendations for biosimilar testing at this point. So a study design, as far as best corrected visual acuity was concerned, it was measured with Snellens, converted into ETDR's letter score for the analysis, and then central subfield thickness with the spectral domain OCT. We use OptoView 3D OCT, and the IOP measurement. All these things were done at each visit. Study design-wise, as I said, primary outcome was 8 weeks for both safety and efficacy. And we did further analysis and we followed these patients up to 24 weeks also. And efficacy was determined on the basis of comparison of BCVA and the central macular thickness. And the safety was assessed on a rough protocol. Basically, I called it that as a clinical immunogenicity. That's what we have been talking and documenting since we are publishing in this area. And the positive immunogenicity was noted if clinician, as I was the only investigator here, if I have noted anything in terms of the inflammation, whether it's anterior or posterior at any point of time in my file. And it was negative if I did not find anything. Study design was usual statistical analysis for the separate arms unpaired t-test and for the baseline data and for the categorical data chi-square test. And we made sure that at baseline in both the arms, Resumab and the Lucentis arm, things were pretty same. So if you look at the demographic data, you have mean age in both the groups same, no different. Male to female ratio same, no different. Even at the baseline, ETDR score was same, around 45 letters. And CMT was also same at the baseline. Mean number of injections during the 24 weeks, till where we followed all these patients, were also similar. So as far as precise results are concerned, this is the table. We could not find any difference at the primary endpoint, which was at 8 weeks. And even further going down the lane, at 24 weeks, there was no difference in terms of the letter score. CMT, macular thickness, was also found relatively same, no different in terms of the analysis, both at primary endpoint at 4 weeks and at the 24 weeks. Safety was, we did not find any kind of negative clinical immunogenicity at any point of time till the 24 weeks. We did have, weaknesses in the study, obviously small sample size, and we had all kind of flaw that any retrospective design would have, including the short follow-up. But to be frank, short follow-up, not a real negative or weakness anymore if you are comparing biosimilar with an originator, because that's how the recommendations are being given now by FDA and the EMA. The only limitation and the weakness I would say, and I accept, that probably we did not categorize, and that should happen. If you really want to compare two drugs, it's better to compare and try to categorize what kind of MNB are you treating with, especially if you have a PCV in that. Although in our group we did not have any PCV patient. And the ideal way of immunogenicity testing is to assess the anti-drug antibodies, which we published in 2019, and now we are seeing that that is happening with brolucizumab. But in a retrospective settings, ADAs are not possible. So ADA usually are the part of any prospective trial, especially the phase 3 trial, when these drugs are being tested. And now ADA has come as on forefront, which was not the case before. Now any trial in terms of any anti-VEGF or biologics have to have ADAs measured. So regarding biosimilars, I think all the speakers have clearly defined, even Jay told, people are aware now. And just to re-emphasize, these are not the copy molecules. They cannot be just copy-paste molecules of the originator biologics, because they do not get the proprietary information from the originator and manufacturer. So they need to do the reverse engineering. So some non-clinically meaningful differences are accepted. And so, drugs can be different. If you want to know more details about what is update, what are the drugs on the horizon, you can refer our paper, which was published last year. And India has a lot to offer in terms of experience. I think presenters presented from Delhi, from Kolkata. So I think each and every part of the country have experienced all positive about this drug. And the way manufacturer has taken the drug and responded and rectified is phenomenal. Means to bring a biologic from a country like India is not less. So we have a lot of lessons, which world can learn from India. Means we will discuss that. Dr. Pramod was pointing about the Canada, so we will discuss that later. And the only aspect that West should learn, and that's what they are doing, is there's an effect called the nocebo impact. Nocebo means negative perception. Biosimilars are blamed and unfortunate to have nocebo perception all across the globe. This is not about the ophthalmology. This is about even the systemic biosimilars. So education is very, very important, and FDA is on it, and FDA is trying to work on this direction. And even if you look at the EMA website, you have the main education page whenever they have biosimilar approval pathway on their website. So I would really like to acknowledge our team. We have published almost 30 articles on biosimilars since last not biosimilars and biologics in last couple of years. There's a lot of teamwork, and I've already highlighted some of the colleagues who have helped us in that. So thank you so much.